Hello, and welcome to the Parkinson's Foundation program, Beyond the Diagnosis, Managing Changing Symptoms. I'm Donna Sperlakis, Senior Director of Community Engagement for the Parkinson's Foundation. I'm excited to be here to bring our Great Lakes chapter community this education program. We're so glad you're joining us today. Please know that you are not alone, and your Parkinson's community is here with you from near and far. For those of you who are newer to the Parkinson's Foundation, welcome. We are the nation's leading community for people with Parkinson's disease, the people who love them, and all of those who are working to end the disease. With our presence in communities across the country and the globe, we believe in the promise of a cure and a better life today for those impacted by Parkinson's. The urgency of our mission really translates into what we do. To achieve our mission, we pursue three goals: ensuring better care for everyone, understanding Parkinson's through research, and educating and empowering the community. We provide free resources, including our website, parkinson.org, educational book series, webinars, podcasts, a hospital safety kit called Aware and Care, our newly diagnosed materials, and of course, our toll-free helpline, 1-800-4PD-INFO, which is staffed by Parkinson's specialists. On the research front, we invest more than $10 million annually to study Parkinson's, what causes it, how to treat it, and ultimately how to cure it. I'd like to highlight PD Generation, which is an initiative that offers genetic testing and genetic counseling at no cost for people with Parkinson's disease. After a successful pilot program, we're thrilled to announce that the PD Generation study has launched its next step, a genetic test that can be completed at home. Now more than ever, we know that having an at-home option is vital to reaching people with Parkinson's. Participants of the study can now submit their test using an at-home kit and review their results with the genetic counselor virtually, all available at no charge to the participant in English and Spanish. To learn about how to enroll, visit parkinson.org/pdgeneration, or you can schedule an appointment by emailing genetics@parkinson.org. So how are we connecting with our communities? You are here with us today, or you being here today with us is a prime example. And it's through our centers of excellence, our local chapters like yours in the Great Lakes, volunteers, advocates, and staff across the country that we bring people together to educate and empower those impacted by PD. We're always looking for ways to keep the PD community connected, so the Parkinson's Foundation has been providing weekly educational and wellness programs in a virtual format through our PD Health at Home series. Join us at an upcoming Mindfulness Monday, Wellness Wednesday, or Fitness Friday by visiting parkinson.org/pdhealth. Before I introduce our speaker, I'd like to thank our program sponsors, Amneal, Synovian, AbbVie, and Abbott, whose support helped to make this event possible. You should know that the ongoing support of our sponsors allows us to offer this unique opportunity to stay connected virtually and to hear from local experts. We invite you to learn about all our program and chapter sponsors by visiting our chapter supporters page at parkinson.org/Great Lakes. So at this time, I'd like to introduce our first speaker, Dr. Aristide Merola. Dr. Merola is a movement disorder specialist at the Ohio State University Wexner Medical Center and was recently made the director of the Center for Parkinson's Disease and Other Movement Disorders. Dr. Merola completed his medical training in Torino, Italy. He focuses on advanced treatment options for Parkinson's disease, dystonia, and tremor disorders, particularly deep brain stimulation, intestinal and subcutaneous infusions, and other advanced therapeutic procedures. That's quite a mouthful. I'm happy to have him here today to talk about managing changing symptoms. So Dr. Merola, I'm going to go ahead and turn it over to you, and you can go ahead and share your screen.
Thank you, Donna. Very much appreciated. And I'm very happy to be here today and have the chance to discuss with you about therapeutic options for early stage and for advancing Parkinson's disease. So first of all, let me say that it's a great honor to be here, invited by the Parkinson Foundation, and the work the foundation is doing is really remarkable. I'm glad to hear about initiatives such as PD Gene, and I really think this is a very important step in the right direction. But moving to the topic of today, what I will talk about is an approach to therapies for Parkinson, discussing what is available, why, and when we should consider every different option. So before jumping into the presentation, I just want to introduce what are my disclosures. I receive speaker honoraria or consultancies, as well as research grant support from both the National Institute of Health, but also from private companies. Of course, the presentation will be very fair and very well balanced. So jumping into the objectives for today, I would like to cover two main objectives. The first one is understanding the symptom progression in Parkinson's disease and what are some challenges that can present with the progression of Parkinson's symptoms. For example, dyskinesia, motor fluctuations, or dystonia. And the second one will be discussing about what are the therapeutic options available for Parkinson, starting from oral medications, but also moving into infusion therapies or advanced surgical options. For example, deep brain stimulation, but we will see also others. The aspect that we need to consider when we speak about Parkinson is this example. So an example in which we represent a Parkinson as a sort of iceberg. And we see that this iceberg has two aspects. One is outside of the water, and this is what we call the motor symptoms. So, for example, the tremor, the gait impairment, the motor difficulties, and this is clearly evident. It's evident to the patient, but it's also evident for the caregiver, the people that live with them. But there is also a big part of this iceberg of disability, which is underwater. And with underwater, what I mean is that this is frequently not so evident. Those are what we call the non-motor symptoms. And these start from sleep disorders, but they can also involve the control of blood pressure, the control of gastrointestinal dysfunction, for example, digestive problems, constipation. And of course, they can also move into cognitive impairment or maybe hallucinations or impulsivity. So there is a tendency towards certain type of symptoms may present earlier in the phase of the disease. Frequently, Parkinson can start with a mild tremor, which is one of the frequent symptoms of onset, not the only one, but is one of the frequent at the beginning. And then later, once the disease progresses, we can start having what we call motor fluctuations. Motor fluctuations typically do not present at the beginning. They tend to present at 3, 4, 5, or maybe even 10 years after the diagnosis. And we will see what we mean with motor fluctuations, but I can start anticipating that basically it's a term to define the fact that the effect of carbidopa-levodopa or other medications doesn't really work well. So patients may start experiencing ups and downs during the day. Certain moment the medication seems to work, and in other moments they do not work anymore. And then towards the advanced phase, we can start seeing postural instability or falls, what we call gait disorders. So we will take a look at what medications can be used in these different stages and when we should consider taking one medication versus another. Of course, in this slide, I wanted to highlight the fact that some medications, what we call the oral medications, for instance, carbidopa-levodopa, are generally prescribed in the very beginning as one of the first options. But when we start having these motor fluctuations, so when we start having these ups and downs during the day, we may want to consider extended release formulations or infusion therapies or deep brain stimulation. And again, this is just a brief introduction. I will go into more details in the next slides. But first of all, I want to clarify why this happens. So why carbidopa-levodopa in the very beginning works, and then later, for some reason, it stops working. So in this cartoon, you can see what happens in the early phase of Parkinson. When a person with Parkinson take carbidopa-levodopa, usually at the beginning, there is an effect that starts to kick in, is a very long-lasting response, and then later gradually wane off. So it is possible to take levodopa only 2 times a day, maybe 3 times a day, but this is sufficient because the duration of each dose is very long-lasting. But then later, at a certain point in moderate PD, we start thinking something like that. We see that the levodopa kicks in. Sometimes we even have an overdosing. So we can have what we call dyskinesia or excessive movements. But then later, there is a wearing off. And so people with Parkinson may frequently oscillate between a situation in which the dosage is not adequate or the situation in which the dosage is even excessive. And this, of course, becomes more evident in what we call advanced Parkinson's disease, in which the effect of every single pill becomes really on duration of a few hours, maybe 1 or 2, and then later off. But why this happen? So one of the main concerns of patients with Parkinson is, I don't want to start the medication now, because if I start now, then later I will develop this phenomena. And so I want to delay the onset of the medication because I want to make sure that this doesn't happen. What I want to show you is that this is not the case. So we can delay the onset of levodopa as much as we want, but this doesn't have any protective effect on motor fluctuations. The reason why these fluctuations happen is not because the body develops a tolerance towards levodopa, but the reason is explained in this cartoon. So what you see here is a PET. The PET is a complex imaging of the brain that can show the dopamine storage. So in other words, what you see in a normal person is an image like this one. You see these 2 red areas that correspond to the dopamine in the brain. You see that there is plenty of dopamine on this side and plenty of dopamine also on the other side. In the initial stages of Parkinson's disease, the dopamine in the brain tends to reduce, but we still have some. So if we look at this brain in the second image, you see that there is still some dopamine produced in the brain. And more importantly, the brain has a buffer capacity. So the medications can be taken only twice a day or 3 times a day because the medication is actually stored into the brain, and then later the brain can gradually release it. This buffer capacity becomes almost 0 or almost lost when the disease progresses. So the reason why we have these fluctuations, these ups and downs, is not because the body develops a type of tolerance to the Cinemet, but the reason is because the storage capacity that is preserved in the very early phases of Parkinson progressively declines. So there is no additional value in delaying the onset of carbidopa-levodopa because there is no such a thing as a protective effect. So looking at what do we mean with motor fluctuations? With motor fluctuations, we frequently refer to 2 opposite aspects. One is called dyskinesia, and the other one, which is the opposite one, is called off time. So those are terms that I'm sure you have heard multiple times, and I just want to make sure of covering them in order to explain exactly what we mean with dyskinesia and what we mean with off time. So dyskinesia are involuntary movements, usually are purposeless movements. And these are movements that can appear in the face, in the upper limbs, in the hands. and are frequently described as a dance-like movements. This happens when there are excessive dosages of medications. So when a patient with advancing Parkinson's disease takes the medication picks up and arrives to the maximum dosage, we can have these movements. But then later, frequently, these movements go down, and that's when we have the off time. The off time means that patients have trouble moving. They feel like they're frozen, they cannot move, they cannot walk, and this is the opposite condition to dyskinesia. So these fluctuations between excessive movements for dyskinesia and lack of movements of off time is one of the challenges of advancing Parkinson's disease. So this is a very old paper that was published in Neurology in 1975, but this is a very important concept. So what the authors showed in this manuscript was that when patients with Parkinson takes levodopa, if we measure the levodopa in the plasma level, in the blood, we see that the levels go up and down, up and down. And if we look at the ability of our patients to move, we see that the same happens. So we have ups and down, ups and down. And this is very well known by people with Parkinson because they take the medications multiple times a day and they experience these ups and downs. But what happens if we maintain the level stable? In this case, in 1975, this was done with an infusion, an intravenous infusion of levodopa. Of course, people with Parkinson cannot go around with a drip, with an infusion. But just for the sake of this experiment, for understanding, we see that when this was done for a few hours in 1975, the condition of patients with Parkinson was completely stable. So if we can keep stable level in the plasma, in the blood, we have a stable motor performance. And that's why we try to move from the normal carbidopa-levodopa into extended release formulation of carbidopa-levodopa. This was initially done with the regular Sinemet. It was called the Sinemet controlled release. But to be honest, it wouldn't work. So there was something wrong in the formulation of the Sinemet, that the Sinemet controlled release can be useful if we take it at bad time, but doesn't really cover the ups and downs during the day. And that's why new medications were developed. And this one in particular was approved in 2015, but it's not the only one. So there are something coming up, and this is the next generation of medications for Parkinson. So a generation of medications that doesn't go ups and down during the day, but remains stable throughout the day. I just want to show you real quick that when this medication was tested in a clinical trial, we see that basically patients at the beginning were treated with this medication, and there was a significant improvement in the number of off hours spent per day. So here, the lower, the better. Then at a certain point, a certain group of patients was given the extended release levodopa, and they continued to do well, and this is the red line. Another group of patients was given the normal carbidopa-levodopa, and they immediately developed more off time. So when we look at the difference between the extended release and the immediate release, there was a 30% difference in the number of hours of off time spent every day, which is huge. So the extended release overall a very good option for patients that start fluctuating between ups and downs during the day. But sometimes it's not even enough. Sometimes we need to be more aggressive because these fluctuations can be very bad. And that's the reason why in these cases, we may have systems that we call infusion systems. Basically, this system consists of a pump that every morning needs to be connected with a little cassette. And this cassette contains carbidopa-levodopa in a liquid form. And what the pump does is basically pumping this liquid formulation of carbidopa-levodopa into the stomach And there is a tube that from the stomach goes into the bowel, into the duodenum, where the levodopa is normally absorbed. And so with this pump, we have now the ability of delivering a drop of carbidopa levodopa every single second. So rather than taking a pill every 3 hours, 4 hours, we can just give a drop every second. How does it work? I can show you the results of the study. So the results of the study showed that people with Parkinson switching to this approach, they had a significant improvement in their quality time during the day. So from 8 hours per day, they went up to 12, and they were followed up for 1 year, and the quality time during the day remained stable. So 4-hour improvement of quality time per day, but more importantly, very stable results. And also the off time. So the time these patients were spending in off went down from 7 hours per day to 2.5, 3 hours per day. And the results also were very stable. But every time we speak about off, on, this is a very generic concept. So how does this translate into quality of life? Because at the end of the day, what we really care for is the quality of life. And those are the results of the study. So the quality of life was measured with the PDQ-39. The PDQ-39 is a scale made of 39 critical questions that evaluate the quality of life. And of course, the lower is the score, the better. And we see that when patients were switched to the carbidopa-levodopa infusion, the number of the scores significantly reduced. So there was a significant improvement in quality of life. And this remained stable for the entire year of observation. When I was in Italy, I guess at this time you have already realized that I have an accent. And as a matter of fact, I came in the United States 5 years ago, but I am originally from Italy. And when I was in Italy, we published this paper in which basically we evaluated the experience over 7 years in people with Parkinson receiving carbidopa-levodopa. And it was remarkable because 90% of them reported a significant improvement in their quality of life. So we asked these people, how would you rate this improvement? Would you say this is a great improvement, a moderate improvement, or only a slight improvement? And after 7 years, approximately 50% of them said it was a great improvement. And another 40% of them said there was a moderate improvement. Less than 10% said that there was a slight improvement. So we are looking for moderate to great improvements with this option. And this doesn't only reflect, as we were saying before, there are motor symptoms, but there are also non-motor symptoms. With non-motor symptoms, I mean constipation, urinary incontinence, fluctuations in the blood pressure, sleep difficulties, hallucinations, memory, depression. So those are remarkable data because they show that before this treatment and after this treatment, there was a significant improvement in almost every one of these non-motor symptoms. But now let's move forward. Let's move to what we call rescue therapies. Rescue therapies means that sometimes people with Parkinson may experience sudden off time. Off time means that maybe you are doing something like you're walking around, you're going to the mall, you're doing something, and you feel like you cannot move. In that cases, you may benefit from what we call the rescue therapies. Rescue therapies are therapies that allow you to take something in that very moment and be able to move so that you feel more comfortable going out and enjoying your activities. This can be done with a subcutaneous injection. So is a possibility of taking a sort of a little syringe that can be done subcutaneously, similar to insulin. And the effect is almost immediate. It takes less than 10 minutes. But now we also have something that can be put sublingual. So there is a little film that in case you feel like you cannot move, you can put it under the tongue and is absorbed within 10 minutes. Or Another formulation is an inhaler that can be inhaled like people with asthma do, but in this case is not for asthma, is a medication for Parkinson. These three options, at least the two of them, are quite new and are useful, but are useful if you experience sudden off time. So if it happens to you, the walking around without any, anticipation, you feel like you cannot move. If this happens to you, this option might be good. Other options. So we see all the time new medications are approved. There are two of them, safinamide and istradefylline, which may be helpful. Overall, for people experiencing a lot of these ups and downs, this medication can provide some improvement. And then later, we also have other medications. For instance, we have an extended release of amantadine that can help reducing the severity of dyskinesia, so these abnormal movements. Or we have a new medication, pimavanserin, which has been approved for the treatment of hallucinations. So for those patients who experience hallucination, this may be a good option. So if we want to wrap up a little bit, we can say that the take-off messages are that there are new extended release formulation of carbidopa-levodopa for people that experience ups and downs. If you don't experience ups and downs, there is no reason for taking this medication. But if you do, there is an opportunity. There are some rescue therapies, including inhalers, for those who experience sudden off periods, which means that some patients with Parkinson, at a certain point, when they're doing something, they freeze and they cannot move. And this can be very discomfortable. For this particular population of patients, there are new medications. For those who have a more advanced form of disease, there are enteral infusions. So this tube that delivers medication drop by drop, second by second. And overall, for those who are experiencing ups and downs, there is also the opportunity for new medications called add-on that can be added and can improve the overall stabilization of the symptoms throughout the day. Now, I want to devote a couple of minutes talking about deep brain stimulation. So deep brain stimulation is one of the most exciting options for patients with Parkinson. And the reason for that is that we have the possibility of putting a sort of pacemaker, which is not a pacemaker for the heart. This is a pacemaker for the brain that is connected to a wire that goes all the way up under the skin and arrives here to enter inside the brain. So this wire enters inside the brain and we place it in very specific areas of the brain that allow us to modulate and remodulate the brain functionality. And this is very important because we can basically control the symptoms of Parkinson without medications. It's a different way. We bypass the stomach, we bypass the pills, and we directly go inside the brain and we directly modulate for that. The efficacy of deep brain stimulation is remarkable. So this is a study that compared the patients taking medications in blue and those treated with deep brain stimulation in red. And you see that in terms of quality of life, immediately there was a big gap. Patients undergoing deep brain stimulation, they immediately felt an immediate improvement in the quality of life. And this improvement in the quality of life remained stable. So the study followed up patients for over 2 years, and you can see that there was still a very significant improvement. And of course, the technology for doing deep brain stimulation has significantly improved. Sometimes patients ask me, but how can you find the right spot? How can you be sure of going exactly in the area of the brain that needs to be stimulated without creating any problems? I mean, we have powerful tools. This is just an example of the accuracy of the brain imaging. So we can calculate trajectories patient by patient. So every trajectory is individualized according to the patient anatomy, to where the blood vessels are, to where the important structures are, so that we can really arrive in the area that needs to be stimulated without creating any damage. And we even have new approaches that allow us to create three-dimensional models of the patient anatomy in the brain. And we can study patient by patient the anatomy of the brain. These areas that you see here are the nuclei that we aim to stimulate. And these fibers are the fibers that we want to stimulate. And we are able to identify for each individual patient the systems of fibers that needs to be stimulated. We have brand new technologies also for the brain stimulation. For instance, we have new leads that allow us to deliver activation only in certain direction. We can steer the activation on the right side, anteriorly, on the left side, according to the patient individual anatomy. And now we can even record for the brain. The new technologies allow us to record the brain signals. And from this recording, we can analyze what is happening in the brain. And there are smart technologies that, according to what's happening in the brain, when they feel that there is an off, the technology gives more power. And when they feel like there is too much power, and patients may start experiencing dyskinesia of extra movements, the technology automatically goes down and reduces the amount of power. So we do have exciting innovation in deep brain stimulation. The technologies we use now is significantly better from the one we were using 5 years ago, 10 years ago. And we're really excited for those of us who work in the field that this is really a great moment to make a big change in the right direction. For those, sometimes I see patients that come to me and they say, I heard that you're specialized in doing the ultrasounds. So I want to spend a few words to explain what the focus ultrasounds is. Focus ultrasounds is a technology that allows to deliver brain surgery without anesthesia, without opening the brain, without drilling, without doing any incision. The way it works is basically with this helmet that is applied over the head of the patient. And this helmet can sense beams of ultrasounds that go inside of the brain, and they became like a laser and allow us to do surgery inside the brain without opening. There is no pain. This is a very promising technology, and Ohio State is one of the 6 centers all around the country that does this procedure. We want to believe that we are the best, but of course, this is a little bit biased maybe. This is a very promising tool. I just want to say this is very new. And the application in Parkinson is still a little bit experimental. So don't consider this as a first option. This is one of the options, but it has to be discussed very carefully with us. While if we go with deep brain stimulation is a very well-established option. This is another of the papers we published. This is again with my old groups in Italy. And we follow up patients for over 11 years. And they were doing very well, even after 11 years. Of course, there are some selection criteria. So some patients respond better to deep brain stimulation than others. And those patients are those with a good response to levodopa, but ups and down. Younger patients and those who don't have cognitive impairment. Because of course, doing brain surgery, we generally want to make sure that we don't create problems in those who are already having some difficulties. I want to conclude and open up to questions with just one other point. So I promised you to discuss also about the non-motor symptoms. So we say that in Parkinson, there are 2 parts of the iceberg. The part that is out of the water, the motor symptoms that everybody can see, and the part that is under the water, the non-motor symptoms. So in this study, and this is a study from 10 years ago, 252 patients with Parkinson were asked some questions about the symptoms they experienced. And so it's interesting to see when it was asked to them if they were experiencing dribbling, constipation, urinary urgency, dizziness, or sweating. Approximately 50% of them said, yes, I do. But the thing that is very important is that approximately 50% of this 50% said, nobody has ever asked me these questions. So it's important. We're starting to acknowledge and recognize that there is a big part of symptoms associated with Parkinson that not only is important, not only is frequent, but is very frequently not addressed. So we are making an effort in order to address these symptoms because most of them can be treated. And importantly, most of them are very bothersome to patients. When we look about what is the healthcare utilization in people with Parkinson over 5 years, we see that there are 37 days on average 18 days on average spent in the hospital as an inpatient because of problems related with Parkinson, and the 37 outpatient visits. And when I looked into, this is a study I did when I was in Cincinnati, I looked into those with orthostatic hypotension, so with these fluctuations in the blood pressure, as compared to those who didn't have orthostatic hypotension. And we looked at the number of hospitalizations, emergency room visits, outpatient visits, and also calls, emails, requests of help. And we added up all together the cost for this. We saw that the cost for patients with Parkinson with orthostatic hypotension was 3 times higher than those without orthostatic hypotension. So this is clearly telling us that this is important and needs to be addressed. But the most important thing, and also my final slide, is this. So if we treat patients with orthostatic hypotension, we see that there is a very meaningful impact. So what you see here is a white column that indicates the number of falls in patients treated with placebo versus those in black treated with a medication for orthostatic hypotension. And you see that there is a huge difference. Over 8 weeks, you see that in this population of 225 patients, the number of falls in those treated became from 3 times lower. So this is something, if you experience orthostatic hypotension, dizziness, lightheadedness, if you feel like you're very wobbly, and check your blood pressure, because maybe you are experiencing this condition in which standing up, the blood pressure drops, and this can significantly increase your risk of falling and having other complications. And it's important because if you tell us, we can address it. So I hope to be on time. And as I promised, this was my last slide. Allow me just to present one little slide about Ohio State before giving you back the word. Thank you, Donna.
All right, great. Thank you so much. That was a great presentation. And I am going to we're going to take a brief pause for a little stretch break. Danielle, are you seeing the right screen?
Yes, it looks perfect.
All right. So we're going to go ahead and take just a little break. I want everyone to just take a quick stretch and maybe refill your beverage, refocus your eyes. Don't go far. We're going to be right back. I would say, I want to get back started here in just a couple minutes. So I've got 3:38. Can we shoot for 3:40? All right. Thank you. All right, so we're back. And if you have questions, we will bring Dr. Merola back again after our next speaker for a brief Q&A. So hold your questions, go ahead and type them in the chat in the Q&A at the bottom of your screen, and we'll make sure to get to those after our next speaker. So I'm going to go ahead and introduce her. Clarisse Goas is a nurse practitioner for neuromodulation at the Ohio State University Wexner Medical Center. Clarisse completed her nursing education at the Ohio State University, and it was her father's Parkinson's diagnosis that contributed to her desire to subspecialize in movement disorders. Clarisse spent 4 years at Wake Forest Baptist Health in Winston-Salem, North Carolina, focusing on treating movement disorder patients. Ooh, hold on, Clarisse.
Good.
I need my screen back. Danielle.
1 second.
I got it. All right, I'm back. Anyway, Clarisse joined the team at Ohio State University in the Advanced Therapies Movement Disorders program almost a year ago in January 2020. And I know we're happy to have her back in her home state of Ohio and here today to discuss some non-pharmacological therapies for managing changing symptoms in Parkinson's. So Clarisse, now you can go ahead and share your slides.
Thank you very much.
You're welcome.
Okay. Okay. Thank you for that lovely introduction, and it is always hard to follow Dr. Merola, but I will do my best. So Dr. Merola talked to you a good bit about different medications and different treatments, surgeries, and interventions that can be used to help treat Parkinson's disease. I'm going to take a little different way of looking at things and look at treatments that are not related to medications or surgeries and talk about how those can help us with our Parkinson's disease as well. So I do not have any disclosures. So we'll talk about two things. Our objectives today are to learn when it is appropriate to expand the Parkinson's care team and seek out rehabilitative therapies or other healthcare networks. And we'll also talk a little bit about understanding the importance of building a support system for emotional wellness and long-term independence in Parkinson's disease. So one of the first things that I'd like to talk about is the importance of the multidisciplinary care team in managing Parkinson's disease. So you usually don't just have one doctor or one nurse practitioner or one person managing your Parkinson's disease. The best way, if possible, is to have a whole bunch of people on your care team, including your movement disorder provider, the physical therapist, your occupational therapist, speech therapist, usually a nurse, social worker, and sometimes a dietitian or a psychiatrist as well. Those should be your core care team, and then kind of reaching out into a little bit further. You may have a geriatrician, you have your general doctor. A lot of our patients have a urologist for all those pesky bladder problems. And sometimes a pain specialist or, your care provider at a nursing home or things of that nature. So there's a lot of people involved in the care of the Parkinson's patient. So switching gears just a little bit, one of the best things you can do to treat your Parkinson's is to exercise. And I know that my patients get really tired of hearing me harp on them for that. But there's a reason that we harp on it so much. Exercise is the only thing that we know right now that can help to delay the disease onset and slow the progression of Parkinson's disease. So you can actually slow your progression by exercising. There's a couple of drugs in trial and a couple of different treatments in trial that we're hopeful may also do this, but we don't know if they work or not yet. We're not sure. But we know that exercise does. And people always often ask me, what type of exercise? And really any exercise is great. The things that have been studied often are dance, Tai Chi, riding an exercise bike. There is some studies on treadmill training, although I'm not super excited about Parkinson's patients using treadmills because they can be a little tricky if you're walking or your gait is not as steady as it used to be. But there are several different exercises that you can do in order to do this. And then the next question people always ask, okay, if exercise is good, when should I start exercising? And my answer to that is typically yesterday, or today, or tomorrow. I do give them a few options. But even if you don't have PD, we know that exercise is good for you. We've heard it a million times in a million different ways. It's good for our hearts. It's good for our circulation, our breathing, our balance, our strength, flexibility, endurance, self-esteem, and always helpful for our mood and sleep as well. So always a good thing. But why particular is exercise so important in Parkinson's disease? Well, there's this concept called neuroplasticity, which may sound a little intimidating, but really truly isn't. It's just the idea that the brain has the ability to change both in structure and function depending on its environment. So meaning that even if you have Parkinson's disease, where your brain is struggling in certain areas and it can make it difficult to move or think, that doesn't mean that you can't improve it at all just by changing the way you do some things. And the changes that can occur when you do this, the brain actually changes in a couple of different ways. It changes on a chemical level, it changes on a tissue level, and it changes on an actual functional level. So that's the part that we like to see, what actually happens when I make these changes. And the changes that we're talking about are really behavioral changes. So doing something differently. In this nice graphic, it shows, when you first start throwing a dart, you're probably not that good. And they go all over, but with practice, you can hit the bullseye many more times. And it's similar to when you're exercising in Parkinson's. When you start working on your balance, it's not going to be that good. When you first go to the physical therapist, your first visit should be your worst, and your last visit should be your best. When you first try to balance on the ball or you stand on one foot, you're not going to be as good at it. But over time, you will get better and better. And not only are these changes happening in your muscles, but they're also happening in your brain. And the neurons are firing differently, and we're seeing different outcomes. Just another graphic showing the same thing. But so here, very specifically, we have these goal-based exercises, such as you would do in physical therapy, or aerobic exercises, which you also might do in physical therapy, or you might be doing at home, like riding an exercise bike. But we see, increased neurotransmitters, which dopamine is the neurotransmitter that we have a little bit less of in Parkinson's disease. So it is important to increase it. And then, we also see that the brain's getting more blood flow, your immune system's improving, your metabolism's improving. And we see this in strengthened circulatory system. And we see it in the basal ganglia, which is, again, the spot where the brain struggles a little bit in Parkinson's. It also improves. And then from that, we just see what we want to see: improved behavior. Your motor symptoms are a little bit better, both the conscious and the automatic. Your cognition and thinking can get a little bit better, and then mood and motivation also improve. So again, very important to exercise. This is a great chapter that was in the International Review of Neurobiology, but it's very specific in why exercise is so important. We can see your motor symptoms improve, your slowness can improve, your balance can improve, your walking may improve. But not only will your motor symptoms improve, but also some non-motor symptoms, such as your thinking, your sleep, your mood, and some autonomic dysfunction. So Dr. Merola touched a little bit on that. Autonomic dysfunction, meaning sometimes you sweat too much, and other times you want a sweater in the middle of summer. So your internal thermometer not working as well, or sometimes your internal blood pressure regulator not working as well. So when you stand up, you get dizzy. Exercise can help a little bit with that as well. And then sometimes it can also help a little bit with medication, and we'll talk a little bit about that more in a later slide. So again, just in case you didn't get enough on the first couple of slides, exercise can slow down your can slow down your progression of disease. It does it in several ways: making your motor symptoms better, making your non-motor symptoms better, improving the way that your medications work for you, potentially improving medication efficacy, and also reducing side effects. All of these things, of course, lead to an increased quality of life. If you're feeling better, if you're moving better, if you're thinking better, you're going to want to be more integrated into your community. Your balance is going to be better, and things are just going to be better overall. So then my patients ask me, when should I specifically, okay, I'm exercising, but when should I specifically seek out physical therapy? If you talk to any of our physical therapists, they will say right away. They can always give you exercises to do at home that you can work on as your disease progresses, and just, get stronger and stronger as you're fighting against the disease. Specifically, if you have bradykinesia, which is just slowness of movement, your movement disorder specialist kind of checks this when they ask you to tap your fingers or tap your toes. We're looking at that. So if you're slowly moving, there were two specific studies, one by Dibble and company, where all they had the patients do was contract their quadriceps, which are muscles in your legs, 3 days a week. And it improved all kinds of things: muscle force, bradykinesia, quality of life, just after doing that for 12 weeks. There was another study that was done, and they looked at over 3 months, 2 sessions a week. There was high-speed power-based resistance training, and it also showed great results: decreased bradykinesia, so that slowness of movement in both the arms and legs, and of course, quality of life improved from that as well. Also, when to see physical therapy, if you have trouble walking, they have proven in several studies that exercise can improve your posture, your balance control, your gait, and physical conditions. And just 4 weeks of this, such as you would do in physical therapy, can improve your walking speed, your step length, so you won't take such tiny steps, and support time, so time you need to use things like a walker, cane, or a loved one. And then if you have trouble turning, that's also a great time to get into physical therapy. Just another study that showed 20 to 30 minutes of specific turning exercises for a little over a month greatly improved a patient's ability to turn. So then my patients ask me, but are you really sure this is worth my time? Because my Parkinson's makes me a little apathetic. And so exercising was not something I liked to do before I had Parkinson's disease, and now I have it and I want to do it even less. So are you sure that I should exercise? And the answer, of course, is yes. And we typically with a physical therapist if you can. But a couple more studies just to reinforce that point. If you do balance training, it obviously improves your balance and it reduces your fall rate, not only while you're doing it, but typically for about 12 months afterwards. Similar with Tai Chi, it can improve your motor symptoms for 6 months, even if you stop doing it. Dance therapy for 12 months, and probably the most impressive is progressive resistance training, which can sometimes be lifting weights, but sometimes is also your own body weight and things, can improve symptoms even after stopping for up to 24 months. There's been studies that absolutely show that professional physical therapy slows the decline and restores the function in PD patients. And then patients often ask me, when do they notice the most improvement in symptoms? And it's usually around 30 minutes after you finish exercising or working with your physical therapist. That is when you may feel the absolute best. And then again, not only will it improve your motor symptoms, but exercise can actually also improve your cognitive function. So you think a little bit better when your body moves around. And then one of the most striking things that sometimes we forget to tell patients is that exercise also can improve the efficacy of levodopa, improve motor response, and decrease the risk of dyskinesia. Now, some of these studies are a little controversial, I will tell you, but it has been proven a time or two that exercise actually makes your levodopa work better when you take it, and could potentially decrease your risk of dyskinesia. So switching gears just a little bit, when is it important to, now we're done talking about physical therapy, when is it important to seek out a speech therapist? Again, speech therapists will tell you immediately, as soon as you get your diagnosis. The more you can work on your voice, the more you can strengthen it, doing exercises, singing, yelling, whatever you can do to make yourself as loud as possible can make things easier down the road. Typically when people seek out speech therapy, however, is when they're tired of repeating themselves to their loved ones, When people constantly ask you, what did you say? Can you say that again? I didn't hear you. That can get frustrating. So that's a good time to consider speech therapy. And then another time we don't always think about is when you're having difficulty swallowing. So speech therapists are great with helping swallowing troubles in Parkinson's disease. Oftentimes patients get very worried when they have swallowing trouble, which I guess completely understandable. But there is some swallowing that we can, and speech therapists can improve, even if you have Parkinson's disease. So what we typically do is we'll order a modified barium swallow. And that is the easiest test you'll ever take. They are going to watch you eat and drink things dipped in barium. And then afterwards, at least here at Ohio State, we have the speech therapist come out afterwards and say, these are the muscles that weren't really doing their jobs. And these are some of the exercises that we can do to improve your swallowing. So they're really great, wonderful people to reach out to when you have those issues. Another great addition to your care team is the occupational therapist. When do we seek these folks out? Typically early on, we seek them out when you're having trouble using your hands. So either from that slowness of movement, that bradykinesia, or if you have more tremor, sometimes that they can be really helpful in finding ways to work around things. A lot of times my patients say, I'm having a lot of trouble using the mouse for the computer or the keyboard. And these folks can give you some help with that. I've also even had an occupational therapist help a patient who really wanted to work on his boat. So they also can get really creative if you have some interesting issues going on. When you have trouble doing things around the house, they're great. They have, workarounds for things and different ways to help you with that. And then they're really very helpful when you're starting to notice you're maybe falling a little bit more around the house or just not feeling as steady, or you're thinking about the future, perhaps, grab bars in the shower, things of that nature, maybe a ramp. They're really helpful about how to make your home as safe as possible. They can often do evaluations in the home for that and give you a little better idea of some upgrades that might be best. And then another very important member of your care team should be social work. Sometimes we forget about them, but they are so important to us. So we use them a lot when we're coordinating home health or home services. They're wonderful for that. And we use them also a lot when we start to notice that maybe your caregiver is starting to need a little bit more help. Maybe they're, burning the candle at both ends, trying to keep everything up. That's a great time to work out to social work and figure out what resources are available locally in your community. There may be a lot of great things, a lot of great programs that you just aren't aware of. And they are the people who know everything about that. And then another time that we love to reach out to social work is depending on how you are at different stages of your disease. So when we're talking about long-term care options, so some folks like to plan very far ahead, and as soon as they get their diagnosis, they want to plan ahead. They want to think about things like if they would need to go into assisted living or a retirement community, they want to tour them, they want to know which one they want to go to, and they want all the paperwork taken care of. Great time to reach out to social work because there's a lot of paperwork involved in that, and they can help you navigate that. If you're a little more fly by the seat of your pants type of person, that's fine too. When you start to realize that maybe you could use a little more help, maybe a retirement community or assisted living or even, full care facility is for you. They can really help you navigate this paperwork, figure out the insurance, and just figure out what is the best way for you to go. They can be very helpful in that process. So we talked about your medical care team, but there's also a really important role for your non-medical care team. There aren't a lot of studies done about this, but there was one study done just last year, where they really noticed that the burden of care was associated with higher daily caregiving time and female gender of the patient, and was significantly increased in the spouse of the patient, which is not really surprising. Your main caregiver will probably fill the bulk of the load. But what was important to note that they also noted is that in the spouse group, better understanding of the caregiver correlated with less burden of care. So this is something that nurse practitioners, we really like to harp on a lot, is that we have to understand the disease in order to best manage it and in order to fight Parkinson's disease in the best way that we can. And so that's when we really start talking about the rest of your support network. So, you need more folks on your team to battle this disease. And the best way to do that is to educate yourself, educate your friends, educate your family, educate everyone. Obviously, everyone on this call already realizes how important this is because you're trying to educate yourself even further about the disease. It is much easier to deal with something if you know it's coming, if you have an idea of what's coming, if you know where your resources are, if you know how to help yourself. And so I always tell my patients, the more information that you know, the better. So attending events like this is great. Another way to educate yourself is every time you go to your care provider, your movement disorder specialist, bring your list of questions ahead of time. How often are you doing something and think, oh, I need to ask them about that. And then when you get to the appointment, it's been, a couple of weeks or months and you don't remember. And then it happens to you again and you think, oh, I need to ask them about that. So we love to see lists. Always bring a list of your questions and we're happy to answer them. And then my second helpful tip is that when you don't understand our answers, please ask us to explain it again. Sometimes we are a little bit guilty. We've explained these things a couple of times and maybe we went too fast, or maybe we need to approach it from a different angle. It's more important to me that you understand it than it is how much time it takes. So please, always ask again, bring your questions. We're happy to answer them. And that can really help you be independent longer and to help everyone feel just a little less stressed in general. So again, we talked about who's on your care team here. We talked a little bit about our physical therapists and occupational therapists and speech therapists and our social workers and all those good people. But let's talk about your friends and family. They want to help you. They do, I promise, at least most of them. And they're there to help. And the more you educate them and the more you help them help you, the easier things can be. Also, your local support groups, I know with COVID, we're really not meeting as often as they used to, but some of them have some online options, which isn't a bad thing. And then there's just your completely online support groups for those of you who really like that option as well. But there is definitely a lot of good things that can happen when you can talk with folks who are going through the same things as you are. And if not for you, then for your caregivers, for them to also discuss some of the same things that are going on. And maybe everyone has a little bit different tip or trick that they can give to you to help you navigate this disease as best as possible. Remember that everybody needs help sometimes, especially if you have a neurodegenerative disease. If you have a larger group that can help you, that are educated and they know about Parkinson's disease, then you can really ensure that no one gets burnout and that your caregivers all are ready to go and happy and doing well themselves, because that's also important. Remember too, I know I have a lot of my patients that say, I don't want to burden my family. I don't want to burden my children. I don't want to burden anyone. And that's completely understandable. None of us want to burden anyone. But sometimes you're really burdening us even less, if you want to think of it that way, because the longer that you're able to be independent and do things on your own, that's better for you and for everyone else. So, leaning on people is not a bad thing. We also know that when you have a good support system, when people are helping and you don't feel alone, your mood and emotional well-being are absolutely going to be better. So again, it's good for everyone. And it's just a good way to support yourself with this disease. So just a couple of messages, a couple of take-home messages. In case you missed it from the first part of my talk, I know my patients, if any of them are listening, are probably laughing a little bit, but yes, exercise is still the most important thing that you can do to battle your Parkinson's disease. There is nothing else that we know that will slow down your progression. That is a very powerful statement. There is nothing else that we know that will slow down your progression. I promise you, we are working on things in research right now. We are working on pills. We are working on IVs. We are working on gene therapy. We are working on all of these things to battle this disease, to fight this disease, to cure this disease, but we don't have anything yet. So the best way to empower yourself is to exercise and to do it routinely. I tell all of my patients, I want you to exercise 30 to 45 minutes a day, most days of the week. Ideally on an exercise bike, going fast and slow. If you have to plop it in front of the TV and go quickly during commercials and more slowly during your show, that's fine. anything that you have to do to convince yourself to keep doing this is really what I would like, and which is really the most helpful thing. Secondly, don't forget those other members of your care team, your physical, occupational, speech therapists, and your social workers. They're really crucial. They're really wonderful human beings, and they know a lot of things that can be very helpful. And then lastly, please don't forget about your friends and family and all the people who want to help and support you so that you can be as independent as possible and feel as good as possible for as long as possible. And with that, that is the end of my part of the talk. Thank you for listening to me. And I'd be happy to take any questions along with Dr. Merola.
All right, great. So we're going to bring Dr. Merola back. Clarisse, thank you so much. That was a great presentation. We did have a few questions come in during your talks, and we had some that were submitted during the registration as well. So we're going to take some time now and go through those. So I'm going to, we have a little, I've got my little document here. So I'm going to go ahead and start asking you a few of these. And so Dr. Merola, the first one's actually for you. Can you distinguish between dystonia and dyskinesia with PD? So can you give us a better kind of example?
Yes, that's an excellent question, and I apologize because I think I didn't cover that very well in my talk. So thank you for bringing this up because I think it's very important. So what we mean with dyskinesia, dyskinesia is not painful, point one. Dyskinesia is an extra movement that usually is a movement in the head like this, or it can be a movement in the hand like this, but it's not painful. And frequently, people with Parkinson who have dyskinesia, they're not even aware of having that. It is something that usually the family members notice, and maybe they are concerned because they're not used to see these movements, but this is generally not bothersome for people with Parkinson. Dystonia, on the other hand, is generally not so visible, but is very painful. Dystonia means that usually the foot in the morning can become very stiff, very rigid, or not only in the morning, it can happen also throughout the day. Dystonia usually happens when the medication is wearing off. So dyskinesia happens when there is too much medication. Dystonia frequently happens when there is not enough medication. So it's important from a treatment standpoint because for dyskinesia, we need to figure out a way to make this ups and down a little bit more even throughout the day. So avoiding the peaks when a patient has dyskinesia is because he's taking too much medication or because he really has a big fluctuation. Dystonia, we generally treat it increasing the medication, so in the other way around. But the patients with dystonia may also benefit from Botox. Botox, I mean botulinum toxin, the same kind of injection that is used for the wrinkles. It can be actually given in the muscles that are very painful, and it works pretty well. So that's a very important question. Thank you for asking.
Great, great. And I thought I've heard of people having DBS for dystonia. Is that an option?
That is a different condition. So in Parkinson's,
it's a whole other can of worms, huh?
Oh yeah, but I think it's important to distinguish this because it can generate a confusion even in professionals. So it's important to discuss this. So in Parkinson, we can have dystonia as a result of the lack of medications. But the dystonia, there is also a different type of disease called dystonia, but is not related to Parkinson. This usually affect the children or people in young age who do not have Parkinson. And that's a genetic disorder that can benefit from DBS as well. But dystonia, when it is associated with Parkinson, it's because the medications are not working well. And so we need to adjust the medications. Dystonia that happens in children or in other people is a different disorder, can benefit from DBS too, but it's a different story.
Okay. Clarisse, this question's for you. Is there a best time to exercise? So you talked a lot about exercise. Do folks want to do that during peak med times, or when should they exercise?
The studies are there. Dr. Merola, you might be able to speak to this, but I don't think that there's been any clear time that says that it's best to exercise. I think that my patients would prefer to exercise when they're feeling good. So, they tend to take their medicines and time it so that it has kicked in. And they're feeling pretty good when they're taking it. They also tend to do it earlier in the day, which I sometimes tease my Parkinson's patients that there's a witching hour in Parkinson's as the day flies on. And you feel kind of like the Energizer Bunny where the energy is going less and less and less. So if you're going to exercise, I typically think, in the morning, after you've taken your first dose of meds, you've had your breakfast, you're doing well. That is my ideal time for you to exercise. After that first dose of meds is kicked in and you're feeling well, sometime maybe in between your first and second. But as far as actual research shows, anytime you feel like doing it is ideal. It will help you sleep better. So,
that's good.
The earlier, right? The better. But really, just when you're actually feeling pretty good and feeling like doing it. I do have a few of my patients who feel better first thing in the morning before they take their meds, and they will do it very early on. But typically, I would say when you feel like your meds are kicked in and you kind of have the energy to go ahead and do that.
Great, thank you. All right, Dr. Merola, if a person goes through DBS, I understand that depression can be an issue without taking medications. Is that true? And related, are there any other side effects that might be associated with DBS?
That's a very good question. So this happens. So when we started doing deep brain stimulation in the early 2000s, so something like 20 years ago, we noticed that. So there were some patients who developed depression after deep brain stimulation. But we actually figured out why this happens, and now we can adjust for that. So what was happening at that time was that the patients underwent deep brain stimulation, and we took off all of the medications. We were so happy to have a system that can modulate the brain, and so we basically took off the medication called Turkey. But the medications are still important. And so now we tend not to do that. And if we adjust, we only take off a 30, 40, 50% maximum of the medication. And the reason for that is because the dopamine, so the medications for Parkinson, they also have an effect on the mood. So if we take them off, people with Parkinson may experience a withdrawal syndrome. And unfortunately, we learned that the hard way. What happened in the very beginning of the brain stimulation was that there were a couple of cases of suicide. But that immediately created a lot of concern. And there were a lot of studies into that. And we figured out that there was a withdrawal syndrome from the medications for Parkinson because they also have an effect on mood and depression. So nowadays, we adjust the medication very, very carefully, and we monitor for that. And also we pay extra attention before the screening for deep brain stimulation. And if there is any depression, we immediately adjust with an antidepressant medication, and we pay extra effort in monitoring this patient. The other point is this. So when we do deep brain stimulation, we place an electrode into a nucleus that we call the subthalamic nucleus. And we learned that we need to place this electrode in a specific region of this nucleus, which is the posterior part. If the electrode goes too anterior, even though we are inside the nucleus, but if we go 2 millimeters, 3 millimeters anterior, we can induce a little bit of depression. This was not known at that time, but nowadays, with the technologies I showed you, we can really take a look at the nucleus and make sure of placing the electrode in the posterior part. So this is another example of how technology is improving the outcome of deep brain stimulation, and a side effect that was concerning and that now we can address better.
Great, that's great. And I was going to say the images you showed of that earlier were that was really neat technology.
We are working on that. That's also proud of Ohio State, where we really, in terms of imaging, we really do a very advanced protocol.
It's awesome. That's great. All right. Clarisse, maybe this is a question you can answer. So, I hear people say a lot, is it Parkinson's or is this something else? So one question that we have is, what symptom changes or what are things that might make me want to call my doctor?
Sure. So this is an interesting question. So what I always educate my patients about is that your Parkinson's is often reactive to any type of stress in your body. And when we say stress, that's a very big word, right? So stress can include silly little things like being too hot, too cold, too tired. When you have Parkinson's, your body wants everything to stay very, very the same all of the time. And when you have a bad night of sleep or, anything like that, your symptoms might amplify. But in general, idiopathic Parkinson's disease is pretty steady. So if you see a steady uptick where something really gets worse a lot faster, it's usually 95% of the time not your Parkinson's disease. Typically in my Parkinson's patients, they call me and they say, I don't know what happened. My shaking's terrible. I was okay 2 days ago. I don't understand. You've got a cold, you've got the flu, God forbid you have COVID, or usually you have a urinary tract infection. So sometimes in Parkinson's patients, you will not notice any other symptoms. You'll think, but I don't have any symptoms. I'm always peeing with my Parkinson's anyways. I don't feel like I'm urinating any more frequently. I don't feel any burning, et cetera, et cetera. But I always educate my patients, when you see your symptoms turn quickly on a dime like that, typically not Parkinson's, typically something else that can be treated with an antibiotic. Especially for my patients that come like 3 hours away, I'm like, please go see them locally first, but then I'm happy to take you, but I don't want you to come all the way out here for a urinary tract infection. Not that I can't treat it, but it's a bit of a break for that, especially if you're not feeling well. But besides that, the other symptoms, just always ask your provider, because I really feel like Parkinson's does encompass so many things. And as Dr. Merola earlier pointed out, where there's so many non-motor symptoms that sometimes we don't discuss them enough. Your nose running more frequently, that's a sign of Parkinson's. We often don't tell you that. So, if you have a question, again, bring it to us and we'll answer it. But yes, there are a lot of things related to Parkinson's. And then there are, a number of things that I suppose are related to other conditions as well.
Great, good answer. Oh, Dr. Merola, I don't know if this is an answer you've got. You might not have an answer for this one, but what do I do when DBS and meds are no longer working? So I think we're talking about someone who maybe is very advanced, perhaps.
So the first thing to do is to figure out why they're not working. So, it's too easy to blame Parkinson's disease. So we also have to make sure first that the medications are at their best level, and also the deep brain stimulation is at their best level. So some patients receive deep brain stimulation, but maybe after 10 years, 11 years, or something happened. Sometimes the deep brain stimulation is malfunctioning. Sometimes the electrode dislocated. There might be good options to explain why this is not working. So our work is to figure out whether we can improve it. So when a patient comes to me and says, I'm not doing well, the first thing I do is say, okay, let me take a look at your medications and let me talk with you. And every single patient has a different story. Every single patient requires, so Parkinson is so fulfilling for us as doctor, because you really have to be a good doctor to treat a patient with Parkinson, because everyone is a little bit different. And you have to listen the story. You have to understand really what are the little nuances. And then later you can really tweak the medication and make the extra mile. It's not such a thing like one size fits all. And so we need to listen that. And then later, we also need to do some exams to look into the deep brain stimulation. Frequently, sometimes Clarisse calls me and says, I want to do some extra examination in this particular case because I feel that maybe the DBS is not working well. And so we can take a brain scan and we can do a lead reconstruction to see exactly where the lead sits and whether there has been anything wrong that can benefit from a second surgery. Of course, there is also a situation in which everything is optimized, but still the disease has progressed. And but that's the last option. So we are fighters. First, we try to fight back. We try to fix it. And if everything is already at the best, at that point, we say, okay, we have tried everything we could. Am I frozen? Oh, maybe Donna. I think Donna's screen is frozen.
I agree.
Yes, it seems like Donna is frozen right now. So we just have a few more questions while Donna hopefully gets reconnected. Um, Dr. Goas, the next question is for you. I don't have a care partner or any family members near where I live. I'm starting to feel socially isolated because of this. Do you have suggestions for keeping my mood and motivation up? So I'm sure this is a question a lot of folks are feeling right now, especially with COVID and all of the stay at home protocols in place. So anything you can contribute to that question.
Sure. No, lots of our patients are feeling this way. And, lots of patients who don't have Parkinson's are feeling this way as well, with COVID keeping us all at home. And so we are definitely watching everyone's mood very carefully, but with some knowledge that we're all a little low and a little blue. What we have seen and what I suggest for all of my patients is to stay as virtually interactive as you can. I know that is the world we live in right now. It is a little bit strange, but FaceTime, computer support, different support groups, again, virtual support groups. I know one of our local, a couple of our local groups here are doing some virtual support groups, and even some of our folks who aren't so good with the technology of the computer are, they're even doing some phone support groups. So it's really just trying to be reaching out as much as possible. There are, what has been really helpful for some of my patients there are exercise classes that are online that are some are recorded, but some are quote unquote live. So, you've got some other people who are doing some exercise with you, moving around. They all have Parkinson's disease. So something to do. But the most important thing for all of us to do, Parkinson's or not right now, but particularly with our Parkinson's patients, is to reach out as much as possible and to move as much as possible. So keep your body moving and keep picking up that phone, maybe turn off the news, and try to feel as connected as possible with your friends and family who care very much, even if they can't see you or be in the same room as you are.
That's great. Thank you for that. And then Donna, I see that you're back on. Can you hear us okay?
I can. Sorry about that.
Perfect. I'll give it back to you then.
All right. I think we've got probably time for one more question. So Dr. Merola, I just want to ask you, how can you tell if you're taking too much medication or not enough?
It is hard to tell because this is something in which it needs to be discussed with a neurologist because in general, the signs of intoxications from medications are dyskinesia. So when there are too many involuntary movements, so if a patient is having involuntary movements for most of the day, and if these involuntary movements are bothersome, what do I mean with bothersome? So maybe prevents you from doing some activities. You would like to drink from a glass and you cannot because these movements are bothersome. This is one red flag. Another red flag could be hallucinations. Could be hallucinations or confusion. Sometimes too many medications can trigger this. However, I strongly, every time I receive a message from a patient that says, maybe I'm taking too much medication, I always try to say, please come over. I want to see you. Because it is so difficult, even for us, to understand this just based on, a communication via message. Because if we can see the patient, we can really realize whether that is the case or not. Because playing with the Parkinson medication can be dangerous. So every time you have the suspect you're taking too much medication, ask for an earlier visit. We try, sometimes if it's too busy, I ask maybe Clarisse to see the patient and I swing by, but it's important to, to have the chance of coming over to check, maybe quick, but doing it.
All right, great. Well, so I think this concludes our Q&A segment. I'm going to bring my slides back here just a second. So that, where's the rest of my stuff here? Just for some housekeeping items. There we go. Are you seeing my correct screen here?
Yep.
Okay. First of all, I want to thank Dr. Merola and Clarisse for joining us on a Friday afternoon, the end of probably what is a very long week. So we definitely appreciate you being here. If your question wasn't answered today, I encourage you to contact our helpline at 1-800-4PD-INFO, where our Parkinson's specialist would be more than happy to hear from you and likely able to answer many of your questions. For more information about upcoming or about resources or upcoming virtual events, I encourage you to visit our website, parkinson.org. Or for more local touch, you can visit our Great Lakes chapter page at parkinson.org/Great Lakes. This program was recorded and it will be available to view on our YouTube channel, parkinson.org/YouTube. We'll also send a follow-up email that will include slides and a link to the video. So watch for that in the coming days. Last but not least, we hope you'll come back. Please keep in touch and watch for more information on our next Great Lakes chapter program at our chapter website, or you can like our chapter Facebook page, which is, I'm going to go back right here. So you can go ahead and find that and like us there. In the meantime, I encourage you to consider checking out one of our other Midwest region programs, like this one being hosted by our Minnesota Dakotas chapter on January 19th. Next up in PD Health at Home on Wednesday, December 16th is Supportive and Palliative Care, the Best Kept Secret in Medicine, with speaker Dr. Benzie Kluger from the University of Rochester Medical Center in New York. For a complete lineup of our PD Health at Home virtual programs, visit parkinson.org/pdhealth. So that just about wraps it up. Please stay on at the end of the program to complete a short survey, and we hope you'll take a minute to complete it. We love to know what you thought, and we like to hear about other topics you'd like to learn about. So thank you again for joining us from the Great Lakes and beyond. I encourage you to stay well, happy holidays, and come back soon. Thank you very much.
Thank you, everybody. And thank you, Don.
Thank you.